Thanks, John. It's no mean feat to try and make this topic interesting, so I'm going to have an attempt at it. I hardly knew what metadata was when Darryl asked me to talk about it. So what is it? Simply, it's the data about the data. To put it another way, it's like the context of the text. And so it's not the message itself, it's the information around the message. Another way to put it, it's the what, where, when, who, how, which, why of any message that you give. A nice simple example would be a library catalogue. So you go to a library, well, at least this is what it used to look like. You pull out a card and it's got the author, the title, the publisher, the date of publication. It might even have a summary of the content, but it doesn't have the actual content. It's not the book itself. But that file is the metadata related to each book. Another simple example might be if you send out an email or Donald Trump sends out a tweet. There's a message that you type into the email or the tweet, and then there's a whole lot of information around that gets sent with it, such as the date and time you sent it, your identification, the recipient's identification, the type of document, if there's anything attached to it, file type, etc., etc. That is the metadata. So it turns out that metadata is extremely important. Some people would say equally, if not more important than the data, because it's important with regard to data capture, data analysis, interpretation, and data sharing. And I'd like, in just a few minutes left, to give you just a few examples. Of course, metadata has spawned an entire economy of staff and interest, and there's different types of metadata. So there's descriptive metadata, structural metadata, administrative metadata, etc., etc. So there's enormous different classification systems for even just the metadata. The Australian government is no different. They've got their Meteor site, which is the metadata registry, which you can go and have a look at. And it's not just limited to medical data, it applies to lots of different data sets. But there you can find the nationally accepted definitions for different data elements that go into, in our case, healthcare related data. And you can spend hours and days getting lost in it and confused, but there is that resource there that's readily available to help you learn about what metadata is in relation to health information. A more important or equally important question is, what's the importance of it? What's the use of it? So let me give you a few examples, and let's start outside medicine. Go back to this fellow, who is one of the unsung heroes of World War II. Gordon Welshman was a very brilliant mathematician, a close colleague of Alan Turing's, who you will remember from the movies about him, was the guy who broke the Enigma code that the German military were using to communicate between all the different elements of their military efforts during the Second World War. And the Enigma machine shown on the left is the cryptanalysis method that they use to send secure messages from one site to another. And as you probably know from the history, it took a number of brilliant people at a place called Bletchley Park in England to break the code. And Gordon Welshman was one of the prime movers who broke through that code. Now, the importance of Gordon is that I think he's probably one of the fathers, if not grandfather, of metadata, because he was so clever. What he did was, even before the Enigma code was broken, he followed the messages coming out of Germany to the Wehrmacht and to the Luftwaffe, and he could tell from the number of messages, the origin and the destiny of the message, and the volume of messages, where it was likely there was going to be a military activity, and was able to actually direct then the British and Allied forces to prevent it. He was also one of the key people who resolved the problem of breaking the Enigma code, but he's never mentioned, and brilliant fellow. Some of you will remember that Apple and Google and Yahoo and other big providers were roped over the coals about the collection of data about all your phone calls, who you were calling, when you were calling, and the storage of all that information, which they kept primarily for purposes of sending you information to try to sell you more. But of course the NSA got caught out by Edward Snowden, and you'll recall when Edward Snowden escaped from the US to Hong Kong and then to Russia with 1.5 billion pieces of paper that he'd extracted from the NSA. One of the major concerns he had was the fact that the NSA, the National Security Agency of America, was storing all of this and analysing all of the metadata related to phone calls, internet activity, tweets and emails and what have you. And he was concerned about the ability of the US to have access to all that private data. So they're just some examples about the significance of metadata. And what I'd like to convince you is that data without metadata is dangerous, and like in so many things in the real world, a text without a context is a pretext for misleading or misinterpretation. And a classic example of a group that misuses or ignores metadata, in my mind, are the journalists and the tabloids, who will take a comment or a soundbite and misinterpret it and make a flashy headline out of it and completely take it out of context. And as you know, when you drill down and you find out what's behind it, is actually a completely different story. Donald Trump's very good at it as well. So what are the purposes of metadata in the health arena? Well, there are lots and lots, and I only want to give you a few examples. Let me start with a somewhat simple and somewhat maybe silly example to do with hand hygiene. All of you know about the 5 moments of hand hygiene. Imagine I went to 2 different sites and found that one site had a 40% compliance with hand hygiene and the other one had 60%. The initial interpretation of that would be that site B is much better than site A. But if I told you that because I go to Vanuatu, we only have 3 moments of hand hygiene in Vanuatu: before you cook, before you eat, and after you go to the toilet. And I said, that's site B, okay? You would be concerned about the 60%. So a completely different picture once you know what's behind it. Here's another simple example, maybe a bit closer to home. Let's say, for example, you wanted to reduce the amount of potassium used in your unit, and you'd looked at the literature and you'd seen this example in the top left-hand corner from recent JAMA analysis of hundreds of thousands of patients with STEMIs and non-STEMIs, found that in fact the safe range for serum potassium was 3.5 to 4.5, not 4 to 5, like a lot of cardiac units would have us believe. So you wanted to reduce the amount of unnecessary potassium, and you went off and you purchased a nice blood gas machine and put it into your unit, and then found, lo and behold, that in fact you were using more potassium than you were before. Those of you astute will have picked up the fact that the blood gas analyzer measures potassium in whole blood, whereas the lab auto-analyzer measures it in serum. And the range of difference is approximately about 0.4. So your blood gas potassium will always be about 0.4 lower than the true serum potassium. So there, it's just a simple example of how you need to understand the process by which the number was created, or the metadata behind it, in order to utilise the data correctly. Risk prediction models are ubiquitous, and here's just a list of some of them. And as you know, we use risk prediction models for lots of different purposes. We use them for research to stratify and risk adjust. We use them for quality of care, for monitoring outcomes, for benchmarking and comparing different interventions, different sites, even different countries. And the table has a number of columns just showing you that all of these commonly used prediction models vary in their content. The number of variables, the number of diagnostic categories, where they get the diagnostic categories from, the time at which the patient record is screened for the data, etc. And as John Moran often likes to remind us, no prediction model is good. They're all bad. There are only some that are worse than others. So they all have their limitations, is what he means. And it's important to understand the limitations of the prediction model that you're using. In order to prevent misunderstanding, ANZIC's core, quite rightly, provide us a data dictionary to accurately define what is the criteria used to enter whatever the variable is. So what the, as you know, for Apache and Android, it's usually the worst in the first 24 hours for the variable, the clinical variables that you choose. And it's a list of Apache diagnoses. ANZPIC is similar but slightly different in the variables it requires, etc. So this is a pictorial diagram in the yellow of a patient journey through hospital, admission to ICU, exit from ICU, and discharge from hospital. The next line down, the Apache and Android models, collects data in the first 24 hours in ICU and is calibrated to predict the outcome or status of the patient at hospital discharge. The paediatric PIM3 model, on the other hand, collects data within the first couple of hours of ICU engagement, whether that's actually in the unit or a retrieval team that goes out, and predicts the status of the patient at discharge from the ICU. And the COPE model that we use in Victoria, based on the coding data, utilises admission data to hospital to then predict the hospital status. So you can understand that each of these models might give you a slightly different answer depending on which one you use. And this is the very reason in Victoria why we always try and use two models, so that if one is reading, gives a particular signal, then we can test to see if we've got the same signal in the other model. Another good example is the Glasgow Coma score. As you know, the Apache and Android models define that the Glasgow Coma score should be scored as the worst in the first 24 hours if it's a patient with a neurotrauma or a neurosurgical problem, or, but for patients who come in after elective surgery, for example, the GCS should be scored prior to the commencement of sedation or anaesthesia. And so at the bottom, what I've done is just plugged in a standard post-operative patient and the differences you get in the score, whether you put in a GCS of 15 prior to the induction of anaesthesia, or you put in a GCS3, which is present when the patient arrives sedated. And you can see there's enormous difference from 0.7 to 12% difference in mortality, so predicted mortality. So if you use the right-hand estimate, you'll make your ICU look really good, because your actual deaths will be much lower than your predicted deaths. And so here's one example, and the core process is extremely good in that they analyse, and here's an example from one site in the blue line of the number of patients from that site that are scored with a GCS3, and the diagnoses are along the x-axis, compared to the national average in the orange, which is much lower. So this particular unit is scoring GCS3 much more often than the national average, except for the 1 point where it refers to post-cardiac arrest patients where you'd expect the GCS to accurately reflect it. So just an example of how the metadata behind GCS is really important and can make it a difference in what your outcome from your research is or your monitoring. Another example is that because the Apache model collects data within the first 24 hours, it's hard to use that model to benchmark your treatment within the first 24 hours because you can collect the data at any time during that period. And we know that 30% of your discharges and deaths occur in that 24 hours. Another important point is when you collect the data. So here's an example in the blue line of Apache 3 being scored at admission to hospital or ED entry at the time a patient's discharged from ED and then worst in the 24 hours in ICU. And you can see that depending on when you undertake your analysis or your measurement of the Apache score, your outcome will vary. And then finally, one thing that we've done recently is look at sepsis fatality rates as an example. And as you know, sepsis fatality rates appear to be falling dramatically. The difficulty is sepsis admissions are rising dramatically, particularly the low acuity group. And we know that all risk adjustment models will over-predict risk in the low acuity patients. So if you have a model that over-predicts in the low acuity group and you have more of those patients coming through your unit, the fatality rate will appear to decrease, and if it's not risk adjusted properly, you end up with a false analysis. And if you adjust for that difference, what we've found is that there's been little change and certainly no statistically significant change in sepsis outcomes in ICU in Australia and New Zealand for the last 15 years or so. So I hope that I've shown you that metadata is important for definitions, quality, analysis and confirming your results, and that context really does matter. Thank you.